This week on the BackTable Podcast.
If I have a high enough index of suspicion, my first go-to is getting a collection of a sample and testing for beta 2. And if that's negative, but my clinical index of suspicion is higher, or if we have insufficient sample, those are typically the times where I might consider this a CT cystonogram and MR cystonogram. You also have to just have a good open conversation with your radiologist or neuroradiologist, because those exams tend to be a little bit more challenging from a performance perspective. And so you have to have a good working relationship and trust their exam with their procedure to ensure that you're getting an adequate study done.
Hello, everybody, and welcome to the BackTable ENT Podcast. My name is Gopi Shah. I'm a pediatric ENT, and today we are in studio. I have two awesome guests with me today, both rhinologists. I have Dr. Satyan Sreenath, Dr. Sat. He's a rhinologist practicing at Indiana University in Indianapolis. You may remember Sat from BackTable ENT episode 207 on bioresorbable packing materials and rhinology. And with him today, we have Dr. Sanjeet Rangarajan, a rhinologist practicing at University Hospital's Cleveland Medical Center in Ohio. And they are here today to talk to us about CSF leak evaluation and management of the anterior skull base. Thank you guys for coming and being here. Welcome to the show.
Thank you so much.
Thanks. This is exciting. Thanks.
This is super exciting. Before we get into it, can you tell us a little bit about yourselves and your practices?
Yeah. So born and raised in Florida, somehow made myself to the Midwest home after a while, and been there for the last 4 years, practicing since 2021 at Indiana University. A lot of my practice is sinonasal and skull base and orient. Probably about 60% sinonasal, chronic sinusitis, nasal congestion, nasal obstruction, and then about 40% skull base. So skull base tumors, working in conjunction with neurosurgical partners. And then particularly, as we'll talk about today, is managing CSF leaks and encephaloseals.
Awesome. Welcome to the show, Sanjeet. Tell us about yourself.
Yeah, thanks so much. So I'm also an academic rhinologist. I practice at University Hospitals in Cleveland, where my practice is, I would say, tends to be a little bit more on the inflammatory side these days, about 60 to 70% inflammatory, and then the rest of the 30% is tumors, both sinonasal, intracranial tumors, and then certainly encephaloseals, CSF leaks, all the exciting things that we're about to get into today. Before that, I was at the University of Tennessee in Memphis, where I had a pretty large skull-based practice and actually saw many people with these issues on a regular basis. And so excited to be here and discuss with you guys some more.
Awesome. So let's just get into it in terms of patient presentation. Mm-hmm. I guess location. Is this something that you see usually initially as an outpatient evaluation? Is this ever an ED consult or an inpatient consult? Tell me where you see these patients and how do they present?
Yeah, I think all of the above. I think it depends a little bit on kind of your practice situation and, where you spend a lot of your time. I think, myself personally, in an academic institution, I certainly see my fair share of patients who are either referred directly with a known CSF leak or have serious concern for a CSF leak. We may see these people in the outpatient clinic, but certainly we have a pretty significant presence in the ER as well as, managing the inpatient consults and services. And so patients who are involved in, trauma or may have had previous surgery, may be transferred into the hospital. And so I think we can see these patients in all of the different settings. And I think they all kind of have their different flavor of how they present depending on the location.
Is it usually your primary evaluation? You're the first person to see them? Or are there your referrals from other ENTs or neurosurgeons or, et cetera?
Yeah, I think often, especially in our practices in the academic setting, we're getting a lot of the tertiary referrals. And so a lot of these times patients have been seen previously by either another ENT in the community. Oftentimes, though, I have gotten some patients from primary care offices, family practice docs who send in for nasal drainage. This is one of those signs and symptoms that I think can be often overlooked and missed in a lot of situations, as we'll kind of present during some cases today, right? When we think about nasal drainage and postnasal drainage, oftentimes, yes, this is more benign and unlikely to be a CSF leak, but I think it's one of those things, if you keep it on your differential and you continue to think about it, it actually might be something that'll present more often than you think. And so oftentimes I will see, usually as a referral, but these are things that when I see a patient who has had, chronic nasal drainage or chronic headaches or other signs and symptoms that may be concerning or history of meningitis previously, I'll have that in the back of my mind and think about, is this something that hasn't been worked up previously?
Yeah. So how often is it, a patient coming in for, rhinorrhea, whether it's allergic or vasomotor, and it's like, wait a second, I think we're dealing with a different animal here?
I think that surprise comes, it's not terribly often. I mean, maybe once or twice a year, at least in my setting, most of the time. And I think, we live in this age of, very easy access to information. And, so I was going to add that I occasionally get some self-referrals, patients who are saying, I haven't gotten better. I did some research. Could I potentially have a CSF leak? I looked you up. It sounds like you do some stuff with this. I'll be honest, it rarely comes as a significant surprise, but that's no reason to not be vigilant, I think. These cases of chronic drainage, masquerading as a CSF leak, or vice versa, CSF leak masquerading as rhinitis, they do happen.
Yeah.
So,
yeah. In terms of symptoms, I think of the salty metallic taste. We mentioned headache, obviously the clear rhinorrhea. What are some of the, we think of those as classic symptoms. How often is salty metallic taste, and how specific really is it? Or what other symptoms come up, or red flags like, hey, this isn't common, but this is usually points to keeping CSF rhinorrhea high on your differential?
I think when I look at these, and you look at these in multiple different perspectives, so I think you can look at these as spontaneous CSF leaks, which has its own connotations, past history, or in the setting of patients who've had prior surgery or prior trauma. And so I think you look at those in two different lenses. Those patients seem to be on very different ends of the spectrum, even though they kind of come to the same situation of a CSF leak. And so when a patient's had trauma, or patients had history of prior sinus surgery, those are the patients where you think more aggressively about looking back at CT scans, looking back to see if they have a known skull-based defect or bony defect. Are they at risk for developing CSF leaks, or have they had an occult CSF leak previously? And then the second category of spontaneous CSF leaks, which is traditionally seen in the setting of idiopathic intracranial hypertension, and we'll get into that in further detail. But, that's one of the, driving factors of why people get these spontaneous CSF leaks is that increased intracranial pressure. And that usually tends to be a different patient demographic. And so you think about that patient population, that definitely tends to be on the spectrum of obese patients with significant sleep apnea. Typically female patients are generally more at risk when they looked at demographics and the prevalence of IIH in the general population. And so kind of having your red flags and your radar up when you're seeing this patients either in the setting of past trauma or surgery, or in the setting of a true spontaneous leak, those are the kind of categories I usually look at them.
With respect to the salty metallic taste, though, I think it's an interesting point of discussion, because I rarely find myself actually asking that question, because it can be so subjective, and depending on the situation, or if someone is doing rinses, or is a sinusitis patient, they probably have reason to have a salty taste in the back of their mouth. Likewise, someone who's been involved in a trauma that could potentially cause these issues, they're usually not in the best state necessarily to be asking that question. So I don't know. In my experience, it hasn't been that sensitive of a question.
Yeah. Particularly the patients who are using saline rinses or sinus rinses that are itself inherently salty, right. Or in the setting, patients with an acute infection might describe some of that purulent drainage to be metallic or to kind of have an off taste, right? So yeah, I think that's one of those classic questions that we in training kind of understand to be the case, but in truth, in theory, it is not a very sensitive test when you're thinking about picking up a CSF leak.
Are there some symptoms that are more common with the spontaneous etiology, and some symptoms, like do you get more headaches with spontaneous, but with a history of trauma, maybe you have more history of recurrent meningitis or something? Is there something that kind of tips you off one way or the other if you can't tell based on, or is it mostly history more than the type of symptoms that push you in the direction of etiology?
Yeah, I think it really has to be a 360-degree evaluation. I mean, I think, someone who has a spontaneous leak, they could get a meningitis, just like someone who's had a iatrogenic or a traumatic CSF leak. So for me, it is extremely contextual. Sat mentioned potentially some certain demographic factors. Well, I'm sure we'll talk about, weight and obesity and, potential risk factors for a spontaneous leak. To me, I think the most sensitive question that I ask, I call it the pillow test. I ask people who have potentially spontaneous CSF leak, does your pillow get wet, after you wake up in the morning? Is there leak, water stains on your pillow? To me, sometimes identifying whether something is unilateral or bilateral, or the volume of drainage, that can help you lead to a slam dunk diagnosis. But personally, it's really hard to say because they had this must be the etiology or this must be the answer.
In terms of those risk factors for IIH, we mentioned risk factors for that female obese. In terms of OSA, is that an independent risk factor, or is it related to the obesity, or do we understand the pathophysiology if it's an independent risk factor of why OSA leads to that?
So I think we're still trying to better understand that. I think it probably goes all hand in hand along with the obesity factor, and so there's some comorbidity there. But I think they've done some preliminary work in looking at in patients with obstructive sleep apnea, generally at night when they're having true obstructive episodes, or if they're having episodes where they're increasing their intracranial pressure, particularly with hypoxemia or other factors. I think there are situations where patients are transiently increasing their intracranial pressure because of the sleep apnea. And so, yes, that more common than not is probably seen in the setting of obesity, but I think there are other factors here that patients with severe sleep apnea who may or may not be obese may also be at risk for developing spontaneous CSF leaks, or at least be at risk for developing idiopathic intracranial hypertension.
Does CPAP make it worse or better? If we have a leak, is that a...
Well, in theory, the idea is that if your CPAP makes the sleep apnea better, reduces the frequency of the apneic episodes, that would hopefully help the IIH. And if it's helping the IIH, then hopefully, reducing the chance for developing a CSF leak. But, it's one of those diagnoses where chicken or the egg, right? So is it patients have IIH and develop CSF leaks? Usually that's the general case for spontaneous leaks, but not all IIH patients develop CSF leaks. And so what's the tipping factor, right? So there's a larger prevalence of patients with IIH in the population, and not as big of a general population of patients with active CSF leaks.
In terms of other risk factors, we talked about the IH group. We've talked about trauma, whether it's been a history of a fall or an accident, or from a history of surgery. What other risk factors? How often is new diagnosed tumor presenting with a CSF leak? And, what else are we needing to think about in terms of risk factors or potential etiology?
Yeah, I mean, it's possible. Generally speaking, though, when I see an intracranial tumor that's entered the sinonasal cavity, or vice versa, sinonasal tumor that has invaded into the intracranial space, I still don't see it presenting with a spontaneous leak very often. I would normally see something like epistaxis, nasal obstruction, other symptoms that could be confused with chronic sinusitis that present first. Has that been your experience too?
Yeah. Typically that's the case. And also the tumors that generally they'll plug the leak if they're really closing off that communication itself by the tumor itself.
Right. We have to remember there has to be a durotomy in order for there to be CSF leak coming into the nose. That dura is intact, even if it's being stretched. Typically it's not going to cause a leak. Yeah.
In terms of meningitis, does that help or hurt? Right? And there a theory that meningitis might help scar the area and maybe seal it off.
Well, I guess we look at the perspective, who's it hurting or who's it helping, right?
Yeah.
So is it helping the patient? Probably not to that degree from the meningitis perspective, but from a pure etiology of the leak itself, there is some, the inflammatory process may spontaneously seal off that leak. And so typically if I'm seeing a patient with a history of meningitis, and if they're coming into the ER, if there's concern that, there's spontaneous leak and they're developing meningitis because of this, when do you intervene, right? And so my approach is if they're actively infected, I won't actively intervene, because I don't think that there's, the worry that from a reconstruction standpoint, are you going to get progressive infection? In these scenarios, typically it's not an active sinus infection causing the meningitis, but I don't really know the answer to that question, right? Because sometimes patients present and they come to the ER and they'll get a tap and, confirm meningitis. And then they'll ask you as the scope surgeon and say, all right, what are we going to do about it, right?
Yeah.
And so they're not actively leaking. And if they don't have a fulminant infection that you could say, oh, we need to go in for sinus surgery to address this, when do you intervene? I don't have a great answer to that question.
Yeah. I think I differ a little bit. And I think you're right in that I'm not sure that the objective answer exists. But in general, if a patient is in the ER, is getting admitted for meningitis and there's clinical suspicion for a CSF leak, typically I would have them admitted and treated for meningitis, typically IV antibiotics, close observation, allow them to stabilize. Generally, these patients stabilize pretty quickly and are feeling much better, but I actually will repair them that admission. And I don't, and again, part of the evaluation is, you'll do imaging, you'll, presumably identify where there may be a leak and have a good target. I had a good anecdotal clinical experience with that approach, and so that's why I do it, but I can certainly see the other side of it. I mean, and there are many cases in otolaryngology where we do not do surgery in an infected field. There's countless, examples of that. For whatever reason, I think, again, once people stabilize, white count comes down, meningeal symptoms, resolve, patients are feeling probably well enough for discharge. I've typically just gone in to repair them at that point and have had good experience.
And because we're thinking that a lot of these patients don't have an acute sinusitis. Is the field not bloody, congested, like tight, all that stuff? I think of, during an acute infection, we try not to operate because of those reasons. Or when we do have to for like a complicated acute sinusitis, there's always like, oh God, okay, we got to make sure we have hemostasis because it's going to be tight. But for that situation, it was okay because
the inflammation is in the meninges, and so typically you're going to have, presumably fairly normal sinuses, and so the difficulty of the procedure will probably be the same regardless of when you intervene. At least that's what I think.
Yeah, it's interesting though, because I think we'll tease this out in two different ways, just so we're not confusing anything. But patients will present, particularly kids, right? Pediatric patients come in with intracranial infections or meningitis or maybe an epidural abscess secondary to a sinus infection, right? And so, in those situations, you're not treating a CSF leak at that point. You're treating the infection and the infectious etiology for the intracranial infection or spread versus, the patient that comes in with maybe a history of chronic nasal drainage, maybe a prior history of a positive beta 2 confirming active CSF leak, then developing meningitis. So I think two different etiologies for their meningitis.
And that one we're saying is not from an acute sinusitis because even though it's all right there, we sometimes assume it is. Talking about physical exam. What is part of your physical exam? And when we think of classic things like the halo sign and things like that, does that mean anything to you?
Yeah, it's a great question. Again, speaking outside of context, and depending on how these patients present, physical exam is usually going to, certainly encompass robust otolaryngology physical exam, but focusing on typically nasal endoscopy is going to be very instructive, to me. But I'm also looking, patients walk into the office with a tissue or a tissue, put up their nose. That might be all I need to see, in order to have a pretty good sense of what's going on. But you're certainly looking for drainage. Patients who say that it's positional, I'll certainly, do a dandy maneuver and have them lean over and try to reproduce it, probably try to collect some of the fluid in the office. But otherwise, I'm looking for other signs and symptoms of other types of disorders, chronic sinusitis, vasomotor rhinitis, trying to exclude other diagnoses. And then again, with nasal endoscopy, sometimes you'll find small encephaloceles, medial to the middle turbinate, things that you can actually see without having done surgery for a patient. So that's where I focus most of my exam. And then certainly a lot of times these patients are getting referred. So there is, quite a bit of clinical documentation that you sort through to try to piece things together.
The halo sign, is that does that mean anything to you?
Yeah, it's funny. We were just joking about that. I think, the halo sign is something that over time has been very ubiquitous and passed down from, trainee to trainee. And we both work with residents and we'll get that report sometimes. I've found, and I think it's been represented in the literature, that the halo sign is not the most sensitive or specific test for CSF leak. Things like saline and blood and, all sorts of different other materials can present with a halo. And so I don't really have that push me in one direction or another, including in postoperative patients who may have a clinical suspicion of CSF leak. A halo sign is not going to necessarily, make me look one way or another. I don't know what your thoughts are.
Yeah, no, absolutely. It is one of those signs and symptoms that has been passed down prior to the ability to do cysternograms, prior to the ability to do beta-2 transferrin testing on fluid, right? And so this was the historical sign. Patients come to the ER, 30 years ago and said, oh, well, a haloing sign from, a car accident or some kind of battle trauma. But as has been shown, as you mentioned, anything essentially mixed in with CSF, mucus, blood, essentially can still halo. And so it's really not a specific or a sensitive test in that regard. We still ask, there are still ICUs in our institutions that ask that question to patients. They'll collect fluid and we'll get pictures through our EMR of the drainage. And I appreciate the fact that people are looking for things. I appreciate the fact that maybe people know about it, but in reality and practice-wise, it's probably not really changing my direction of treatment one way or another.
You'd mentioned the Dandy test, so that there's a formal name for that. It's not called the Dunk test.
Right. Yeah, that's right. Yeah.
That's my outline of like.
Yeah. I mean, hey, dunk test is good, whatever. Yeah. Leaning them over, dandy maneuver,
When you lean them over, maybe this sounds silly, but I'm legit. When you lean them over, how I remember being taught to have them so that their head is close to their knees and like have something collecting and wait for like 30 seconds to a minute. Is there a way to do this properly?
Yeah, when I do it in the office, I'll typically start talking with the patient. We'll go over the history. I'll do a basic exam, and I'll ask them if, can you reproduce it? Do you think you could produce some fluid right now? And they'll say, yeah, maybe I can. I said, well, let me give you a vial, and why don't you bend over? I want you to bend over at the waist while you're in the chair as far as you can. And then we're just going to keep chatting and talking and, that sort of thing. But I want you to do it for several minutes. And so they'll do it, and usually about 30 seconds in, we'll be chatting, and they'll look up at you to answer a question. I'll say, no, you have to lean over for. So I have them lean over for a couple of minutes at the waist. I let them hold a specimen cup, and, usually they'll say something like, I feel like coming, and then, sure enough, sometimes, it'll start to beat up on the nose, and we'll start to get some droplets. Or in other cases, we don't, and we send them home with a vial in those cases. And so to answer your question, I don't have a hard and fast, angle of bend or a specific amount of time. Again, a couple of minutes is usually plenty. If it's going to come, it's going to come, and you can let them hold the vial in case it doesn't.
And you need like a milliliter, like it's kind of a large amount, no?
Yeah.
An adequate sample. That's, I think, the other tricky part is how much is enough.
So typically, you'll actually, they actually say that for the testing for beta-2 transferrin presence, you need usually about 2 to 3 milliliters. So it's usually a little more than you would expect. But in the reality, you think about it is that if it's truly CSF, right, we were talking about this earlier, it doesn't tend to hide as much, right? It's typically that, if it's truly a CSF leak or a truly spontaneous leak or post-trauma or post-surgery, it's not as black and white as sometimes we think about it. So if it truly is CSF leak, collecting 2 to 3 milliliters is usually not that difficult because it's usually going to be pretty continuous. And so from just going back to that positioning of how you're collecting it's tricky because when you think about, the locations of where these leaks can come from, right? If it's a leak in the ethmoid, a leak in the frontal sinus, or some kind of defect there, it's usually you can lean forward just a hair and it's going to start to emanate. But then you think about the lateral sphenoid recess, or you think about all kind of more, difficult locations that typically find it, it may pool in the sinus. And that's why patients will sometimes say like, yeah, I was working out or I was at the gym and that's when it started happening, but it doesn't really happen, in your office. And so I think providing patients with proper instructions, and just like Sanjeet said, I'll send patients home with a sterile specimen cup to collect, and then technically you're supposed to keep it on ice, or you're supposed to keep it refrigerated, and so we'll give them the appropriate instructions so that sample doesn't denature, so it does our ability to test for that presence, so that protein isn't inhibited, so they'll know exactly how to keep it on ice and then deliver it to the lab. And so I think it's important to do that because you can potentially get false negative results if it's not transferred appropriately.
Because I was going to ask you, every once in a while you'll get inadequate specimen. Does that rule it out for you, or do you have them do it again? Like, what do you make of that result? And it may be putting it into the context of how the patient's presented to you, their history and what they look like and that kind of stuff. But, every once in a while, confirming, I think, can be very difficult. And then the second thing is always kind of localizing, which we can kind of get into.
Yeah, I think with the insufficient sample, again, I think we're dealing with like two groups of patients. I think you have the patients where it's not equivocal, where you already have a good sense of what you're dealing with, and those tend to be the patients who can very readily produce it for you. And then you have the patients where it is a little bit more equivocal, and maybe you get lucky with a positive test that's going to help you, go in the direction of whatever your intervention is going to be. However, again, if a patient has a compelling story or compelling imaging or compelling anything, and then there's an insufficient sample or even a negative result, I think, the road doesn't exactly stop there. I think you do whatever you can, and we're going to talk about that, I'm sure, about how else you can make this diagnosis. But I think, making sure patients, always have a specimen cup with them or sending them with another specimen cup, just like, hey, when you can get it, you can keep trying. That's an easy way to do it.
In terms of differential, we talked about rhinitis, vasomotor, allergic. How often could you ever get so much rhinorrhea from either of those where it can be confusing for CSF? And, what else do you think about as other reasons to have that clear runny nose that may not be from a CSF leak?
Yeah, I mean, I think especially in your elderly patients or elderly population, the prevalence of non-allergic or vasomotor rhinitis is fairly high, at least in my patient population. And so the CSF leak is not the first thing on my mind when I'm thinking about seeing these patients who come in for presenting signs and symptoms of chronic dripping nose or chronic nasal drainage, because, Sanjeet can probably attest to this. 80% of our clinic patients are coming in saying that they have a drippy nose or they have postnasal drainage or they have chronic rhinitis, chronic rhinorrhea. And so, it is important to keep that under differential, but more often than not, your diagnosis is going to be more likely chronic rhinitis or vasomotor rhinitis. And so, parsing out, is there laterality to the drainage? Parsing out, is there times when the drainage seems to be worse, such as when you're increasing pressure? So when you're going to the bathroom or you're at the gym or you're bending over, does it seem to be worse, right? So usually in those situations, vasomotor rhinitis or allergic rhinitis shouldn't typically change with positional changes, right? And so I think trying to parse that out as you're doing your history and your exam is important. And then just again, the other risk factors we mentioned earlier, right? I mean, those would be the bigger red flags if they have some other more of those comorbid conditions as well. But I think looking at the laterality, looking at timing, looking at exacerbating factors helps you differentiate between some of those.
Going back to the scope exam, this might sound silly, but do you usually decongest the nose for these patients so you can look up or look lateral? Do you always go in with a 30? Do you start with your standard 0? Do you have them Valsalva? If you can't find anything, do you have any tips or tricks for how your scope, if your suspicion's high?
Yeah, I bet this comes down to kind of personal technique and training to a certain extent. I use a 0 in the office unless I'm looking for something specific in a particular sinus or in a particular direction where I need the angle, and I can use a 30 or a 45. With respect to decongestion, my standard exam is to look first without decongestion on board, and then I'll often spray a decongestant in order to look at more sensitive areas, like often the middle meatus or the sphenoethmoidal recess, places that we kind of very standardly examine as part of this. But the reason I like to wait on the decongestion is because, again, as a rhinologist, we're also looking at, comprehensive examination. If someone's not coming in very specifically with a diagnosed CSF leak, maybe they do have congestion, other things like that. It's nice to be able to see, what is the effect of your oxymetazolone or whatever you're using on the turbinates, how much do they shrink? It may help you arrive at a different diagnosis. And so I do use decongestant in my practice, but just specifically, I know, some folks will have people sprayed before, the physician enters the office. And I think that's okay too. It's just not necessarily how I do it. How about you?
Yeah, no, I think I actually do a very similar method. So I use a 0-degree scope just for mostly out of convenience, in that's what's readily available in our clinic. And that's usually what I use for debridement patients as well. And I typically do the same where I won't decongest necessarily up front, because most times, unless you're looking for something also diagnostic by the decongestant itself, right, seeing if they have a true response to it, you can get a decent exam, right, in most patients. And even if you had a 30-degree scope, I know there are some others, where I trained also some of my mentors would use flexible scopes for some of these reasons to try and get into the middle meatus or see a sphenoethmoidal recess or look medial to the middle turbinate. In reality, in a non-operated patient, even with a flexible scope, it's going to be pretty tricky to see all the way high up into the olfactory recess or out all the way back to the sphenoethmoidal recess. We might see the edge of it or the tip of it. And so in most of the situations, even if there is a CSF leak without an encephalocele, chances are you're not going to be able to visualize it, because then you're saying, all right, well, am I going to have them do a Dandy maneuver while scoping them, right? And so in reality, if you truly are looking for something, that's probably how you need to do it. Or are you saying, all right, well, they're coming in for congestion, and then you realize, coming out of their middle meatus is this encephalocele. And so then it's usually more obvious, and that's where the scope really helps you. But I think it's pretty tricky just using the scope as a tool for identifying a CSF leak without an encephalocele.
But I will say the other utility of, performing an endoscopy, even separate from the diagnosis of a CSF leak, is you're also, let's just say they do end up having one, you're also using this as part of your preoperative planning, right? Because as we think about and move towards different treatments, we're thinking about, what are our reconstructive options? Do they have comorbid pathology? What's their exam like? Like how easy is it going to be to perform? If it's something in the olfactory cleft, like am I going to have to do a septoplasty? How do they tolerate the scope? Are they going to be easy to read afterwards? This is obviously getting into general rhinology, but I mean, those are some of the reasons why I also perform an endoscopy, even if the likelihood of finding a leak maybe with that is on the lower side. Unless you've probably gotten lucky, you see an encephalocele like medial to the middle turbinate, in the olfactory cleft. I mean, but a lot of times we don't see anything. Yeah. You're right.
So your next step after, let's say you did endoscopy, you don't see much, maybe collected some beta 2, it came back as insufficient, but your suspicion is high based on, let's say, a history of trauma, or maybe it's the female that's obese, for example. Do you go straight to imaging next, or what's next as part of your workup?
Yeah, I think it's reasonable. I would start with a CT, volumetric CT scan of the sinuses in order to, look at the sinonasal anatomy. And I think, in patients who do have CSF leaks, I find that to be an incredibly sensitive test without the use of cysternogram or an MR. I think a volumetric CT can actually detect it in many patients, whether it's an opacified ethmoid cell, adjacent to the skull base, or maybe one sphenoid that is opacified where the other side is not, or maybe you do see a large encephalocele, or you see one of the other kind of less likely pathologies we talked about, like tumors, et cetera. But I start with just a regular CT scan, and I feel like that answers a lot of questions.
Yeah. And it's also, in general, usually the most cost-effective and also least invasive when we think about the other imaging studies. And oftentimes, right, whether you're thinking of post-trauma or in the setting of spontaneous CSF leaks, like Sanjeet said, if there's a true bony defect, right, that it's going to heighten your clinical suspicion. Obviously, an encephalocele will be easier to identify, but I mean, they can be as small as a very small bony defect in the cribriform or at the, lateral lamella, and then or in the lateral sphenoid recess. And so a CT oftentimes is usually all you need. And so if you have a diagnostic confirmatory test, whether it's beta 2 or clinical suspicion of a CSF leak with a associated CT scan that shows your bony defect, I oftentimes will not get an MRI in those settings. I'm curious how you'll do just your Sanjeet, is that for the setting of CSF leak without a either large associated encephalocele or, other, or am I looking for other concerning signs, ruling out, is this some other pathology? I typically won't get an MRI in those patients. I think a CT scan is probably going to be sufficient, because now you're using it for two reasons. Number one, you got it for your diagnostic purposes. And then number two, you're going to use it for your neuronavigation and CT guided navigation during surgery. But do you get MRIs in your routine CSF CSF leak patients?
I've changed over the years of my practice, and actually when we talk about how we fix these, I've also changed in how I've done things over the years. I think in the beginning I was ordering a lot of MRIs. Again, I felt like I needed to. And then I started to think about, well, what question is this answering for me? And, how is it going to change, what it is that I do? And I think I actually can't think of an easy example in which it really helped me all that much, except for, maybe in cases of, tumors and things where you're already going to be getting an MRI for different reasons. So I agree. I think, based on your clinical examination, maybe you have a positive beta 2, and then you do a CT that is showing you some concerning anatomy in some location. That's enough to make the diagnosis, create a surgical plan, take them to the operating room, and then it serves as your baseline for postoperative surveillance as well. So I totally agree. I think in many cases, a CT is all you need.
Does location matter? If there is a big defect near the sella or at the sella near the carotid or cavernous sinus or pituitary, I mean, we like the bony anatomy for some of those structures too, but does the MRI help you based on location for anything like that?
So I think you have a couple options in the situation you mentioned. I think if you uncover a defect that's, particularly in the sphenoid sinus, where there are multiple structures that are at risk, the carotids, the optic nerves, the sella, many different parts of the skull base, I would actually consider a vascular study, potentially a CT angiogram, that's going to obviously show the vasculature in much more detail. I think you certainly could consider an MRI at that point. Again, that's more of a kind of a technical piece to help you plan your surgery. I don't think it would necessarily help me with the diagnosis at that point. But yes, I mean, there are certainly exceptions but again, those are examples in which there's a clear benefit to getting those scans. A simple dehiscence of the ethmoid roof, an MRI probably won't add much.
And then just going a little bit, let's say the CT isn't as clear. Let's say there is maybe a little bit of ethmoid pacification, but maybe it's just the lamella looks thin, right? Like sometimes it's not a very obvious. How often do you consider a cisternogram, whether it's CT or MRI? Where does that come into your practice if it does?
Yeah, so it's a good question. I think oftentimes have steered away from the cisternograms, mostly out of patient comfort. They are not easily tolerated exams because patients are essentially getting, spinal taps and actively getting intrathecal dye injected and have to undergo this procedure that they're getting scanned at the same time. And so, or scanned immediately after. And so when you think about patient comfort, patient tolerance, I take a couple of different factors into play. So at least my algorithm is, if I have a high enough index of suspicion, my first go-to is getting a collection of a sample and testing for beta 2. And if that's negative, but my clinical index of suspicion is higher, or if we have insufficient sample, those are typically the times where I might consider this a CT cisternogram and MR cisternogram. You also have to just have a good open conversation with your radiologist or neuroradiologist, because I think those exams tend to be a little bit more challenging from a just a performance perspective. And so you have to have a good working relationship and, trust their exam with their procedure to ensure that you're getting an adequate study done. So I'm using it less frequently. And then kind of piggybacking off of that, I don't know how you do your Sanjeet, but there are situations where if I have a high enough index of suspicion, beta 2 is equivocal or maybe non-diagnostic, but there is a clear bony defect at the ethmoid, skull base, or along the fovea, they have an opacified cell immediately adjacent to it, then I'll get an MRI as my next step in that situation. And if there's maybe an encephalocele, maybe not, I sometimes will plan to say, okay, well, I think there's a high enough index of suspicion. We're going to go to the operating room and I'll counsel patients and consent essentially for 2 different potential procedures. And so it's kind of going off in a little bit of a tangent, but there are some situations where you'll counsel patients that if there's, prepare them for, this might be a sinus surgery, this might be, routine functional endoscopic sinus surgery. Maybe this is a mucocele that caused erosion of the bony skull base and it's not actually a true CSF leak or skull base defect, versus, this could be something that I'm going to plan for reconstruction. And so those are very different conversations, and those can be challenging for patients because, it changes all the dynamics of, I'm not doing this at the surgery center, or I'm not doing this, in the ambulatory setting. This is something we're doing at the hospital. This is something we're preparing for potentially having to admit you after surgery. I don't know what your perspective on that is, Sanjeet, but if there's any patients where you take to the operating room thinking that you may have 1 or 2 procedures potentially.
Yeah, I think there's a role for exploration. Getting back to your question about cisternograms, I think I can think of only one time where I would order one, and I think that's in a patient with a positive beta 2 transferrin and a totally clean CT.
Yeah.
Like no opacification, no mucosal thickening. It's just totally clean. And then maybe, because then you have to start to think about, how can that be? And also you have to start to think, is it coming from the nose? Is it coming from the lateral skull base, via the eustachian tube or something else like that? But, then you widen. But I can think of some rare circumstances where I would use a cisternogram, but I rarely order that test. And I think in the situation you're talking about where there's clinical suspicion and then a CT that shows an opacified cell, maybe with or without a skull base dehiscence. If it's something that is going to need to probably be treated surgically regardless, I would consider, exploring and being prepared to either reconstruct it or, perform whatever else needed to be done. I don't know if I would order an MRI in that case or not necessarily. I think I could go either way. I think it depends on the context again.
The only thing I thought about that in that setting, right, is that we'll go off on a tangent on lumbar drains momentarily, but in those patients, would a lumbar drain potentially be helping from an exploration standpoint when you're saying, all right, we're going to do fluorescein through your lumbar drain. Is that going to help us identify if there's a true CSF leak? But then, you're also saying this patient may not have a CSF leak. They may not have an encephalocele. And so those are the patients where I actually don't opt to do upfront lumbar drains. And we can talk for a while on, the utility of lumbar drains and, where we use them diagnostically, where we use them therapeutically. But these are all the things you're kind of thinking about in your mind when you're going into these cases, right? You generally want to be prepared to handle this is going to be this pathology, this is going to be this case. But there are, unfortunately, in some situations where you kind of end up going plan B or going for the audible.
Let's kind of get into it because it's still part of the local confirming and localizing section. And then we'll do part 2 with cases. But so, when you go in and you have one plan of, is this a sinus pathology? And the second plan of, it could turn into a skull-base repair. That's also prepping the OR. So you have that component, which depending on how often and what, sometimes the OR is fine with that kind of stuff. Sometimes it's a big to-do. But in terms of order of things, do you look in the nose first? Do you consider a lumbar drain intrathecal fluorescein? Do you just do intrathecal fluorescein? Do you start with those things? Because then you have to kind of think of equipment, positioning. How do you organize that in your mind? And maybe it's case dependent. But
yeah, I think any case in which I'm going in thinking that there is a likelihood of a skull-base dehiscence, CSF leak, encephalocele, anything like that is not something I'm taking to the surgery center, up front. So I think in terms of location. So then once you're in a place where you're comfortable, where you have the materials, you have the equipment, and you have the backup, then, you're in your comfortable space and you're ready for anything, whether it's a skull-base repair or it's just a simple sinus surgery. And you also have the potential to, we can talk about admission and those types of things, but we can dive into lumbar drains. And I don't know about you, but I rarely am taking someone to the operating room where I just have no idea. You know what I mean? And so, but if you really truly had no idea after everything that we've talked about, all of the different kind of like diagnostic gestalts and clinical, inference, et cetera, then I think, sure. I mean, lumbar drain with intrathecal fluorescein could be, part of your detective work. I routinely don't use lumbar drains in patients, including in spontaneous leaks. I anecdotally have had good experience with that, but I understand, particularly many of these patients have, extraordinarily high pressure, and a lumbar drain can increase your, likelihood of success. I've found that I've not needed lumbar drains, and also, lumbar drains do cause complications sometimes. And so I'm sure we have a lot more to say about that, but I'm generally not like kind of thinking about, do I need to do a lumbar drain before a case for the most part.
Yeah, no, I think I'm on the same page for you. And, our backgrounds and trainings probably speak to that, right? From, Jefferson has published a lot of literature regarding use of lumbar drains in the perioperative period around surgery. I think the University of Alabama, Brad Woodworth had published a study that essentially looked at, the utility of lumbar drains and also their drain protocol after surgery. And so they very expedited use of their lumbar drain post-operatively, and they'd actually be pulling these lumbar drains, 6 to 8 hours after surgery versus the traditional 48 to 72 hours. And they were not noticing any significant deleterious effects from that. They were still seeing the same clinical outcomes, same overall success rates. And I think that's where, in the last 5 to 10 years, our use of lumbar drains from a therapeutic standpoint has significantly changed, because right now we have better reconstructive methodology, we have better approaches from an endoscopic perspective, we have vascularized, non-vascularized repair if we think that's required. And so I think the utility now in lumbar drains has overall gone down. Now, that being said, there are patients, if you have the other potential utility, and so there are some patients where, if we have a clinical suspicion that they have elevated intracranial pressure, right? The best time to measure that is with the drain. And because you're doing your tap at the same time, so measuring your pressure up front will get you a sense for what's that intracranial pressure at. And so when you think about, under 20 millimeters of mercury is where we think about is in the range of normal. And so a lot of these patients will come in, 20 to 25. But if you have a patient that's coming in, 35 to 40 or significant elevated pressures, their risk for recurrence is higher. And so, historically or not historically, depending on your comfortability, the lumbar drain, in theory, how it's working is to help that reconstructive repair, essentially that patch from below, stick better. And so, is it 24 hours that makes that difference? Is it 72 hours? But it's difficult to make that decision without knowing some of those parameters. And so the lumbar drain allows you to get that pressure measurement up front. Now, you look at the flip side of that coin is if they're actively leaking, you might actually have a lower pressure than you would expect. because their pop-off valve is open, right? And so we can go off on a whole tangent about this, but I think it is not black and white on the utility and use of lumbar drains nowadays with our reconstructive approaches. I probably am very similar to Sanjeet in that in more routine repairs, I don't think there's a lot of utility to it. I think it's adding some complication, adding morbidity potentially. It's keeping him in the hospital for potentially longer. So I think it depends on your comfortability, whether or not you're using perioperatively. To originally go back to your original question, I don't think I'm in the same boat. I don't think I'm at least using it from a diagnostic perspective, and I would not use it in that sense that I want to place a drain or do, fluorescein injection just for diagnostic purposes. Because most times if I'm using, I would say 100% of the time if I'm using a lumbar drain, it's because I know definitively there's a leak or an encephalocele that I'm repairing.
Is intrathecal fluorescein for localization part of your practice ever in the OR?
Yeah, I think, when I think about all of the cases over the last 10 or so almost years, I think most of these leaks can be localized preoperatively. So again, and if you're going to the operating room and maybe you don't have a beta 2 and, you don't have any objective clinical information, you probably shouldn't be putting in a lumbar drain or even being in the OR. So, so it's just rare that you find yourself in that situation. I hope you don't find yourself in that situation. So.
Awesome. Well, I think we're going to put a pin in it here for the first part and let you guys get into it in terms of repair, timing, how to repair. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening and see you next week.